Good morning and welcome to Recipe for Success. As you can see, something's missing this morning. That something would be my guest. I am guessing since she is a doctor, something has come up. So she may be joining us at some point during this show, or we may be rescheduling this episode. But because I had it on the calendar, I wanted to keep my commitment and keep this podcast going. So we're going to pivot. Oh, there she is.
Oh, how are you?
She made it. She made it. Okay, awesome. So I'm so excited we get back on topic on our topic for today, and I'd like to welcome my guest. And I hope that I am going to pronounce your last name correctly. I didn't get a chance to clear it with you first, but Dr. Arti Thangudu?
Pretty close. It's Arti Thangudu.
Arti Thangudu. Okay, thank you. With a last name like Giacalone, I really care about pronouncing people's last names correctly.
I hear you. I'm the same way, and I still mess it up all the time. So if you ever need a refresher, just let me know.
Well, I will respond to pretty much anything, so people can call me anything, and I just am like, okay, whatever. I know that their intentions are good, so I'm never too bothered by it. So I'm really excited for today because Dr. Thangudu is a triple board certified physician who specializes in endocrinology, diabetes, and metabolism. I mean, I wish I could say that that was all she had to her credit, but she's also started 2 healthcare companies. She's a mom, has 2 kids. I mean, I'm in awe. This is pretty amazing. But before we get started and have you go into a little bit more detail, I do want to ask one question right off the bat because I think a lot of people don't necessarily understand this, but I would like, if you would, to explain what an endocrinologist does.
I know. Endocrinology is like this big fancy word that like means nothing to most people, which I think is a little bit unfortunate and makes our specialty a little bit confusing. So thank you for starting with that. So my specialty is, the full name is endocrinology, diabetes, and metabolism. So we take care of patients with diabetes, all types. We're like the diabetes experts. I think it's interesting because cardiologists, everybody knows what that is, but people don't actually know that there's an expert in diabetes. Well, there is, and it's us. We're just hard to find, and there's very few of us. And then endocrinology is the study of hormones. So we take care of things like thyroid disease, other hormones like cortisol issues like Cushing's or adrenal insufficiency, growth hormone issues, testosterone, PCOS, perimenopause, menopause, low testosterone in men. So anything related to a hormone, that's our specialty. And you might be wondering, okay, well, what does diabetes have to do with hormones? Why is that lumped into one specialty? Well, insulin is a hormone. So that's why, and there are other pancreatic hormones as well at play with diabetes, and metabolism. So we take care of things like lipid disorders, high cholesterol, also endocrine hypertension, things like that. So it's a specialty that applies to almost every single person, or at least somebody's relative or friend or something like that. So even though it's a big fancy word that nobody understands, we take care of a lot of diseases that you're probably aware of.
Thanks for explaining that because I thought I knew exactly what an endocrinologist did, but because anytime I do have somebody on, I always do a little deep dive and I'm like, oh, all these other things too. How interesting. So I just wanted to make sure that we could really kind of explain that and set the stage. But let's kick it off by, now that you've explained what you do, I would love it if you would introduce yourself to the audience, tell everybody a little bit about your background and how you got to where you are now.
Yeah, so I guess I'll start from the beginning. So I have loved this space of medicine for a really long time. I think even before I knew it. I grew up in a community, I'm Indian, with a lot of metabolic disease, and we have very, very high diabetes rates, heart disease rates, premature cardiac death occurs way too often in our community. And I sort of grew up with it. My dad had a heart attack when I was 3. So he was very young. He was in his 30s, and that's one of my first memories. And my grandpa had diabetes, and he lived with us growing up. So I grew up like pricking his finger. And so I was being exposed to this from the family side, the caregiver side, from a very young age. And then, you know, didn't really think about what field I wanted to go into, or that this was affecting what field I would ultimately choose. But then when I went to medical school, I thought I was going to do one of the like sexy specialties, like a surgical subspecialty or something like that. But I just kept being drawn to the patients and their stories and the families, and wanting to really know my patients and help them through challenging conditions. And diabetes was just everywhere, is just everywhere. Um, and it was, of course, near and dear to my heart. And so was metabolic disease. And so I think in residency, I realized that I loved the people. So that was what drew me to like an internal medicine field versus surgery. And then endocrinology specifically, because it just felt, the patients just felt very familiar to me, I guess I could say.
Yeah.
Um, and then, yeah, I have loved it ever since. I've always been interested in the soft side of medicine and diabetes. A lot of people go into endocrinology for the other hormonal conditions, but I've always loved diabetes. I thought it was applicable broadly. There's so many people with diabetes and so much space for improvement in that space. And yeah, so that's what I did for my fellowship. And then in my first couple of years of attending, I joined a mega practice. It was a private practice, but it was very, very busy. We'd see 500 plus patients a day. And, it was great training. I think there is value to being in a high volume setting when you're especially a young physician and learning. So I got exposure to a lot of disease processes, a lot of different types of patients. And I'm forever grateful for that experience. At the same time, I just felt, and the patients felt, that they were in a cattle call. And I felt that I wasn't giving my best to my patients. I know that I wasn't giving my best to my patients, because you really can't when you have 5 minutes with a patient, when they have no access to you. They can't call if they're having trouble getting their prescription. And when they call, they're on hold for so long that they eventually hang up. If they leave a message, they don't get a call back for months. It's just, that's not care. And I just felt so stifled in that environment. So I thought, okay, what am I going to do to actually take care of my patients in a way that I believe they deserve to be cared for, and, actually be able to sustain that? Because the problem is, when you're seeing 35 patients a day, it's impossible to give them the care that you want to. And then when the clinic is not well staffed for that either, it's just terrible for really everybody in the
Yeah.
whole circumstance. And so then I heard about direct primary care. Nobody was doing direct endocrine care at that time, but it really resonated with me, the values behind it, the patient-centeredness of it, and it seemed like something I could do, and it seemed really applicable to my field. And so I thought, let me try it and see. And um, maybe it'll work, maybe it won't, maybe nobody will want to see me. But at the same time, all of my partner's patients were asking to switch over to me, even though I was the youngest, brownest, littlest person in the room. So I was like, maybe things are changing in my favor. Maybe people actually will be interested in seeing me. And so turns out that people were looking for something different too. And so the direct care practice has done well since then. And through direct care and learning about the medical free market, people who believe that there should be pricing transparency, because there should be pricing transparency in healthcare. I learned about more employer-based medicine, and we got some interest from employers. So we actually branched off into a second company called Hey Healthy, which works specifically with employers who are interested in decreasing cost, improving outcomes by providing great diabetes and endocrinology care for their employees to keep them healthy, productive, and out of the hospital.
I love that. I want to actually go back to a comment you made a little bit earlier. You said you kind of grew up with it. And it was common in your community. So, are there specific types of communities or ethnicities that are more prone to diabetes, and what causes that?
So, yes, so the Indian community is an interesting one, and I'll go into that in a bit more detail. And but there are other communities like Hispanic populations have high diabetes rates. Um, Also, some African American communities. Some of these things are social, um, social determinants of health related,
Yes.
um, and some of them are physiologic. Some communities simply have a higher propensity for diabetes. So perhaps those social determinants of health are more common in zip codes where they may not have access to great grocery stores or great education, um, great health literacy, those types of things. And but still, Hispanic populations in in normal or well off zip codes still have a propensity for it. And so I think it's more than just the lifestyle or social determinants of health in that type of community. Particularly in the Indian community in the United States, we have a very high prevalence of diabetes despite economically being in the not really in those lower socioeconomic areas as much. And so we certainly have um, genetic predisposition to diabetes, larger effect of the change in diet from a less processed to a highly processed diet when people move from India to the United States. Not so much there's a lot of processed food in India now too. But also I have perhaps narrower vessels, increasing risk of atherosclerotic heart disease or heart attacks, things like that. So I think it's a mix of both social determinants of health as well as some genetic predisposition.
I think that's really interesting, and I think it's not talked about enough because I think that people just say, "Oh, you don't eat right," or whatever the case may be, without understanding that there could be underlying genetic predisposition that makes it much more difficult for them to maintain their blood sugar levels where they need to be. So I think that's really interesting.
For sure, and environment too. I mean,
Yes,
some people are in very stressful environments, whether it's personal stress, work stress. Some people have to be shift workers. That's their only option.
right.
And that increases predisposition to these things. Poor sleep, if people aren't able to be on a regular sleep cycle, that really um, can increase risk. And we see physicians who are shift workers who are otherwise healthy, exercise regularly, eat healthy with prediabetes young, especially in these populations. So it's, I think that we all need to take a step back and stop blaming the patients because one, that doesn't help anybody. So
It does not help anybody.
there's really no point, and it's also not the patient's fault. It's just false. Nobody wants to be sick, and so if we stop blaming the patient and instead seek solutions, I think we'll all be in a better place.
I love that approach. Okay, so you start this direct specialty care clinic, which again, you brought it up. I'm familiar with direct primary care. I love it. I'm a big proponent of it. We don't have enough up here, but that's a whole nother issue. But you're the first person I had heard with a direct specialty care clinic. So I really admire you for taking that bold step and getting out there and, letting people have access to appropriate care if they so choose. I think that's an amazing accomplishment in and of itself. But you said, "Well, hey, that's not quite enough for me. I need to expand my message." So you started Hey Healthy. So let's talk about Hey Healthy a little bit more. I really want to kind of get into that and how that can benefit employers and their members that they care for with their benefit programs.
Yeah, so let me tell you a little bit of the history. So I started the direct care practice and then started working with an employer kind of out of happenstance. I had no idea about this employer-based healthcare space. I didn't know it even existed. And I thought, I'm this brand new young endocrinologist. What am I going to do in this population of people who just have not done well with very good primary care? And I think primary care is great, especially direct primary care. And primary care doctors are wearing so many hats that we love to collaborate with them to take something off of their plate. Diabetes is extremely complex, and we have an entire toolkit that we can devote to diabetes. Um, and so I think in collaboration with primary care, we can augment them and take some of that load away from them. And so I thought, what am I going to do? And then within 3 months, I started noticing that patients were coming off insulin. Their A1C was dropping from like 12 to 6 in 3 months. They were happy, they were engaged, they were doing the lifestyle changes that people were telling them like they need to change the lifestyle, but they weren't going into the nitty gritty of exactly how to do that, how to goal
Right.
set, how to make those baby steps to get to the next level. The same exact people. So it wasn't like this cohort and this cohort being compared. It's the same exact person, literally apple to the same apple comparison of people who had been failing the traditional system or even perhaps better primary care for decades. Were getting better. And then we started collecting data. And in patients that started with an A1C above 9, we had an average of above 3% A1C reduction. So that's like 9 to 6, which takes a patient who's extremely high risk of having a heart attack, stroke, amputation at any moment to very low risk of having any of those things. And then in all comers, patients who had elevated A1C above 6.5, we had a more than 2% decrease in A1C in a very short period of time. Um, and once we started looking at it at a more populations level, I was just like, oh my gosh, this works. And it's so silly, right? Like, it's great care. Of course, it makes people better. Of course, giving people access and time to really get to know their doctor and to build a relationship to eventually trust that person and actually do what they ask them to do. Like, of course, that works. But clinically, one, the traditional healthcare system doesn't allow for that. And two, we don't track it. Like, most doctors don't track their own outcomes. And I was just a nerd. Like, I graduated from fellowship and there were all these new obesity medications. And I wanted to see if they really worked practically because the data showed all these um, great findings. But my patients just, nothing was happening with these medications. This was before we had Ozempic and stuff like that. And so I wanted to see, are these actually worth prescribing? So that's what spurred me to collect data. And I realized with that, like, no, they're not working. They're wasting my patients' money and time. So let's move on to the next thing because it's not working for me clinically. Whether that means I'm doing something wrong or whatever, like, I don't know what that is, but that wasn't working. So then I got really nerdy and started to like really collect data all the time because I wanted to see if what I was doing for my patients was actually working for my patients, because I knew that if it wasn't, then I would want to change my strategy. And that curiosity is what led me to learn what we could do and the potential of an endocrinologist and the potential of a patient. And knowing that, I thought, I could just keep this to myself, but that doesn't seem like the best use of this knowledge. And so last year we decided to grow, and then we founded Hey Healthy this year, just because it was getting confusing to have a direct care clinic where the client is the customer, is
Right.
the patient versus the customer being the employer. Um, and we just keep seeing the results over and over again. And you'll see like beautiful testimonials from patients, and it feels like the right thing to do because it's a triple win. It's obviously a win for the patient. It's a win for the employer because these diabetic complications. That's the other thing. I started looking at claims data. Oh my
I
gosh, I
know.
don't know
It's
how anybody
terrifying.
looks at that without like having a heart attack. But one diabetic patient can cost $1 million. Like, on one hospitalization. And so if we can, in our initial cohort, like, none of those patients went to the hospital in 5 years for diabetic complications. If that alone, it makes it valuable, I think. Um, But keeping these people out of the hospital healthy and happy can really benefit the patient, the employer, and also the doctor. Doctors are getting burnt out, especially in endocrinology. We're a dying specialty. There's only 5,000 endocrinologists and 37 million people living with diabetes. 85% of people with diabetes will never see an endocrinologist due to sheer numbers. And I believe that it's a very valuable specialty, as you might guess. And since it's cerebral, like it's not procedures very much, it's hard for people to grasp that that what we do with our mind and our training can really transform a life. And so I think that creating a space where clinicians who are interested in diabetes, which is the costliest chronic disease our nation is facing, if we can create a space where they actually want to come into this field, that will be the icing on the cake, I think. And our doctors are super happy because they get to spend time with their patients. They get to do what they love to do, which is help patients get better using their clinical skills and critical thinking. And so, yeah, so we've created this beautiful little triple win space that I hope that we can continue to grow.
I love that. I always say you can't change what you don't measure. So if you don't know what the data says, how do you know what your next move is? So I love that you're using that as an action plan for how you develop your practice and how you treat patients. So I'm going to kind of jump to the elephant in the room because anytime you are talking to an endocrinologist, how can we not bring up the massive demand for the weight loss drugs? And I'm going to preface this by saying I have nothing against them. I have nothing against them. I don't have a position one way or the other. I think in the hands of the right physician and with the right patient that they are a very valuable tool. So I don't want anybody to get all up in arms about, one way or the other. I really would like to discuss this from more of an objective standpoint. We know that they were developed as a treatment for diabetics and they have evolved since then. So I would like to hear your take on this situation.
Yeah, it is quite a situation. I think it's like a thorn in every endocrinologist's side for many reasons. One is that we can't get them for our patients, and we're having to transfer prescriptions like 100 times a day. I've already done that many times this morning. And also, we can't go out without people talking about this. So I'm happy to have a platform where I can reach more than one person to talk about this. So, first of all, these drugs are not very new. I've been using them since residency in my endocrinology rotations. They have been out since 2010, 2011. We've been using them for a long time. Even Ozempic came out in 2018. So that was 6 years ago. So it's not brand new. There has been a lot of media attention on them recently, which has led to an explosion of interest by both people, patients, consumers, and compounding pharmacies, and lots of different interests around this space. There's lots of weight loss programs being created with these drugs as well. So I think there's two sides of the coin. Yes, they are highly effective for people with diabetes and obesity. They work very, very well. They're basically first on our algorithm for most patients with diabetes. They not only have reduction in blood sugar effects, but they also have cardiometabolic benefits, renal benefits, kidney benefits, lots of potential benefits for people with diabetes, as well as weight loss. People with obesity are higher risk for getting diabetes, having cardiovascular risk. And so I think they're highly, highly effective, highly useful, and safe in most people. And I know you wanted to talk about how they work, so I'll briefly go over that. What they do is GLP-1 is a hormone that is naturally secreted by the intestine, and it regulates appetite, and it also regulates insulin secretion by the pancreas in response to food. So it works in a couple of ways. One is in people with diabetes, insulin is a hormone that brings down sugar, and their sugar does not come down sufficiently with the insulin their body is producing, or perhaps their body isn't producing insulin at all. And so in patients who still have the cells, like type 2 diabetes, that produce insulin, this medication will actually tell the pancreas to secrete more insulin after the person eats food. So it directly brings down blood sugar in that way. Another effect is it slows down how fast food moves through the GI tract. So it makes people feel full faster. So in that way, it reduces appetite. So people lose weight, which also helps with insulin resistance and improving blood sugars. It also works on brain receptors that kind of reduce that food fixation. You'll hear people with obesity or diabetes talk about something called food noise. They're thinking about food all the time, which actually reduces with these medications. So that's how they work for both diabetes and weight loss. And there are potential side effects, though, like people can have increased reflux. They can actually have bowel obstruction sometimes, very rare, but there have been case reports of that. They can have a lot of nausea, vomiting, especially seen in people who are perhaps using it how they shouldn't, like taking a high dose of it to start. How we usually start these at a very low dose and then up titrate or increase as the patient tolerates. So if nobody is monitoring that, or the patient is using it to lose weight and they don't care, they're like, I don't care that I'm throwing up, I just want to lose weight, that's not really a healthy way to get there. And so there is abuse of these drugs. Also, when we think about a medication, we always want to think about the risk benefit ratio, and the benefit should always outweigh the risk. So if somebody is taking this medication and they don't have an indication, like they have a normal or low BMI and they're trying to get thinner, well, then the risk outweighs the benefit, right? The potential risk of pancreatitis or GI side effects or issues with the medication, as well as the cost, outweigh the potential for benefit. But in our patients living with diabetes and obesity, who have a lot of potential risks of those conditions, like peripheral neuropathy, blindness, heart disease, things like that, well, then the benefit outweighs the risk.
Yeah.
And so it's really important to think about that ratio before you take these medications or ask your prescriber for them, or you prescribe them.
So obviously, we know that for diabetics that are being prescribed these GLP-1 drugs, that they are creating a benefit. They are helping them maintain their health in a better way. We also know that these can be very effective just for straight weight loss. My concern about this whole situation right now is everybody's prescribing them. It seems like your med spas are prescribing them, Costco's prescribing them, Jenny Craig's prescribing them, Oprah's telling everybody that it's the magic cure. If somebody is, let's say, more than 20 pounds overweight, maybe they've got 100 pounds to lose, it seems like a logical, good thing for them to do to get back down to a healthy weight if they've tried other things and that they're not working. What happens when they hit their target weight? Are they on this drug for the rest of their life?
Couple of things there. So one, it is really important to be prescribed one of these by a clinician who knows
Thank
how to
you.
prescribe them.
Thank you.
Because the prescribing of them is not very straightforward. Like, it's something that's titrated. It's not just like there's one dose of these drugs that you give to everybody and that's how it is. There's multiple doses, there's multiple indications to change. They need frequent follow-up with their doctor to assess for side effects or adverse effects, and they should be discontinued if there are adverse effects. The problem that we see is, even I had a patient tell me that a primary care physician, prescribed him 1 milligram of Ozempic to start, just sent it to his house, and with no coaching. That's not the starting dose. And he was also seeing me, and he called me just to see if that was okay. And I was like, no, please stop, please, no. You have to start low. You'll get really sick if you do that. And so if if we don't know how to prescribe it, don't prescribe it. And I know it's like highly lucrative. There's a lot of compounding of these drugs, which is another whole rabbit hole we could go down, but we don't know what's in the compounded medication. So I wouldn't recommend doing that, even if it may be less expensive. I would never inject something into my body that I didn't know what it was. And there's just a lot of people playing the game because they know it's a very lucrative one. And so it's really, really important to do your due diligence, do your research. And it is hard to be a patient out there right now because it's hard to get into an endocrinologist. It's hard to get into a primary care doctor. There's a lot of people who are saying that they know what they're doing who may not. So I see that and I feel that for our patients. But just be careful. These drugs can cause problems if they're not prescribed accurately. And then I lost track of what the actual question was, Nancy. What was it?
Oh, that's okay. I really am concerned about the lack of gatekeeping around these medications. And again, if it's being prescribed by a doctor who's educated on them, I'm 100% behind it. Where I have some real issues is some of these telehealth services, we can call them that, where you sign up and talk to a doctor and give them information that's not being validated, and they're immediately prescribing you something that is lower cost, probably compounded, and all of a sudden you're on this, and then how do you get off, if ever?
Yeah,
And what are the and again, what are the potential side effects? Are you doing anything to support this weight loss? Are you implementing lifestyle changes? Because just the drug, there's got to be more to it.
yeah, the prescription mills. Yeah, so what you had asked about was, are people on this forever? And
Yes.
some people are and some people aren't. So, if somebody has diabetes or they've had long-standing obesity, um, the honest truth is it's going to be hard for them to get off of the medication without weight regain. Is it impossible? No, but it's harder in those cases. But
Gotcha.
let's say somebody had a lot of weight gain in a short period of time, perhaps pregnancy or something like that. They get on this medication, get back to where they wanted to be. That's a more likely situation that they may be able to get off of it. Now, regardless of whether you're on it for a short term or a long term, it is very important to make the lifestyle changes that they support, right? One is healthful eating, of course. I recommend a plant forward eating pattern. That doesn't mean vegan or vegetarian, but just eating your fruits, veggies, whole
Yep.
grains, beans, lentils, those types of things. Um, Limiting processed foods, those types of things. The medication will be more effective if you do that. And also, you'll have more health benefits. And if you're trying to get off of it, making those dietary changes will help that. And then also the other side of it is when people have profound weight loss. I mean, we see people losing 50 pounds, 100 pounds on these medications. When you lose weight, you lose both fat and muscle.
Also.
And you want to lose mostly as much fat as you can healthfully and keep as much muscle as you can. And in order to do that, you have to bear weight. You have to do resistance training. And so if you don't do that, people can have weakness, they can have wasting, they can lose a lot of muscle mass, which especially as we age, we don't want to do that. I mean, we start losing muscle mass if we aren't actively trying not to when we're like in our 30s. It happens young. And so, when patients get older and if they're not doing the resistance training and they're taking these medications, they can really become frail. And we don't want that to happen either. So it's really, really important for providers to take the time to emphasize the importance of the lifestyle changes to use in addition to these medications and not just slap these medications on like they're a cure all, not a cure all pill, a cure all injection.
Yeah.
Because they're not, and weakness can come on pretty fast, especially in our older folks.
Well, and one thing, again, this isn't really your bailiwick, but there's also the issue of the cost. The proven effective ones, such as Ozempic, Wegovy, et cetera, they're about $1,000 a month. And if we then allow that to be covered by health insurance for all people, regardless of whether they have diabetic, co-conditions, if we're just using it for weight loss, how do we afford that? How do we afford that? I mean, it, that that's $12,000 a year per person that's on that drug, and you spread that out among everybody. But we already know that obesity rates in the United States are very high. So if we actually applied that, it becomes unmanageable. And so we have the issue of, we know these work, we know they can be incredibly helpful and they can improve health outcomes, but how do we afford it?
I
And we
know.
got
They're so expensive. And I think that's a huge barrier. And I mean, if you compare to how much it costs in other countries, it's actually very crazy how much less expensive they are in other areas of the world. But I think, um, I've talked to a few groups about that specific question and how do we not gatekeep, but make sure that people are also engaged in other tools to help their overall health. Um, in our in our employer groups, most people are covering them for people living with diabetes.
yes.
I
We
think,
have we
and I think at this point we sort of have to based on the
Yes.
guidelines. Um, with obesity, most people are not. I think if we're thinking about how we can perhaps cover it for some people with obesity, my suggestion is I would say have people engage in a lifestyle program. If they're willing to do that and they're willing to complete a lifestyle program that an employer feels confident is actually having the patient engage with, and is a good program, which is what we do. We have a program where the patient sees an endocrinologist once a month for 3 months. They see a health coach every 2 weeks, and then follow up 3-month follow up with the endocrinologist, continue to see the health coach, and then they can follow up as they need and want after that. I mean, that's pretty intensive education on lifestyle and their condition, and it's an investment by the patient. It's a patient
Mhm.
saying, "Hey, I'm invested in my health and I want to get better, and so I'm going to show up to these visits." And so one way that I have suggested in the past is let's engage these patients in a lifestyle program. If at the end or middle of the lifestyle program we still feel like they need the medication, then if they've shown up to all their visits and they have engaged and they've made progress, then maybe they've earned that medication.
Right,
We
right,
have, because it's expensive. It's not that anybody deserves it or anybody doesn't
right.
deserve it. It's really difficult to speak in that way. But when we're talking about dollars available and dollars to spend, like we just can't, our employers just can't afford it for
Well,
everyone.
there are a finite number of dollars. I mean,
Yeah.
that's just a fact. We have a finite number of dollars, and how do we most responsibly spend them? Again, it's not a question of deserving. I have seen some employers that have put in programs like this where they will pay for the drug for weight loss for a year as long as the member is actively engaged in the program. But then the problem becomes, what happens at the end of the year if they still technically need it and the employer says, "Well, I'm sorry, we only provide 12 months." Then that becomes a whole other issue. I've got a question I'm going to pop up here in a second, but I did want to actually make a comment that I thought was really interesting. Is I have a TikTok account where I just kind of basically help people understand different things about the healthcare system, little short snippets. And one of the things I had talked about was the actual cost of, like, for example, Ozempic. The actual manufacturing cost is about $5. And we just kind of had gone through some math on that, and that got banned. That video got banned, um, which I find incredible because when I go on there and scroll through the TikTok, I see a million consumers on there giving their expert advice on how to best use these weight loss medications. And so I just found that to be fascinating.
That is fascinating and terrifying
It
at
is
the same
because, it was, There was something behind that, because they let all these other ones on there. But I wanted to put this question up here from Olivia. She says, "Is it true that some people have an inability to make the proper amount of GLP-1 naturally?" Dr. Gupta mentioned that on podcast and is supporting this option for those individuals, but also did note that lifestyle factors should be addressed along with longevity of the prescription, which you've basically kind of addressed, but maybe you could address that as well.
Yeah, so the perhaps the production of GLP-1 is impaired. Yeah. So the function of incretin, it's an incretin hormone, they don't act normally. So a person with perhaps a normal BMI who doesn't have diabetes, their GLP-1 works differently and more effectively than somebody with obesity or diabetes. That's why, you know, obesity is a real disease. It's like,
It is.
as an ICD-10 code, it is accepted by like many medical societies as a real disease. And I think it's important to say, like, people aren't obese because they want to be. They don't struggle with weight loss because it's a choice. It's not a lifestyle choice. Some people are predisposed to it. There are environmental issues that can cause or increase the risk of obesity. There are genetic issues. There are true genetic, like mutations that can cause obesity. It's not just that somebody didn't want to do the right things to not have this condition. And I'll tell you, I see a lot of patients struggling with this, and they're not just people sitting at home like eating chips all day, and doing nothing productive. These are productive people, attorneys, doctors, teachers, people who are productive to the community. They're trying, they're making an effort. We do dietary history, sleep histories, social history, like all the histories on these patients. And they're not just sitting around doing nothing. They're trying. The body actually physiologically does not like to change. And so when you're trying to change your weight, even if it would become healthier at a lower weight, the body doesn't want to do it. And so it's more complicated than just eat less, move more, which I think a lot of research and science has showed us recently, or in the past several decades, I would say. Um, but we have to figure out a balance of like, okay, these medications are really expensive right now. What do we do to get them to the people who are going to benefit the most from them and not completely destroy our businesses? Because they could. I mean, they're so expensive. They could be a very large line item for a company that is unsustainable.
Yeah. Well, I really appreciate your objective input on all of this because, I mean, I could talk to you for hours on this subject. But for the sake of time, we need to move on to the fun part of the show. So, are you ready?
Yes, I hope so.
Okay. First question. Everybody gets it. What is your absolute favorite food in the world and can you cook it?
Okay, this is a hard one, and it's, are you Italian?
Well, more or less.
More or less. Okay. Eggplant parmesan, but a very specific eggplant parmesan. Last year I went to Positano and took a cooking class, and we made it. So I have made it and it was amazing. The problem is everything tastes better in Italy.
Well, of
So
course.
I can't recreate it here. So I can only have it again if I go back.
We're gonna
So
have to go back. Well, so I am Sicilian by marriage, and in Sicily they cook a lot lighter than other areas of Italy. So, yes, I can cook a lot of Sicilian dishes, and I even made one this weekend, so that was kind of fun. Okay, so this is one of my favorite questions. What character trait do you admire most in other people, and why?
listening. I think people who take the time to listen before answering abruptly or quickly, I really admire that because I think it's difficult to do that. And it's really difficult to be comfortable in silence. But my dad's one of those people. Maybe that's why I appreciate it so much. But I think people who listen and are thoughtful about their responses are some of the smartest people around.
Love that. So, if I flip the mirror on you, what's the character trait in yourself that you're most proud of, and why?
Um, it's a I think it's a character trait that I've cultivated. And maybe it's not a character trait and it's a habit, but to slow down and to sleep on it before making any sort of big decision. Um, I think that is something that has really helped me in the past few years.
I like that. I think habits do become character traits. You practice them long enough, they become part of you. So I think that's a perfectly acceptable answer. Okay. So, what is one step a person who may be pre diabetic can take to improve their overall health?
I think really sitting down and thinking about what brings you meaning and what is something that you value or you want to get to in your life that makes any lifestyle or makes any changes towards better health meaningful, because a number on the scale or an A1C number, that is not meaningful enough to realize real change. But things like being able to play with my grandchildren on the ground because they're little, or show up for my grandson's high school graduation, or really something tangible that you want that can really motivate you on a deeper level to make strides in your health. I really think that's the first place to spur change.
I love that. Okay. What is your secret talent or something people would be surprised to learn about you?
I'm a diabetes doctor that knows how to make, like, decorate cakes. Like, I can when I was in medical school, as you might think or understand about me, I'm a little bit of an out of the box thinker. And I have a creative side that I felt was just like stifled during medical school. And for people who have never been to medical school, fourth year is like your last year of any sort of freedom before residency. And so it's a little bit lighter. So in my fourth year spring semester, I took a cake decorating class and a photography class to get out my creative juices.
And the cake decorating stuck.
The cake decorating, it's stuck. I still can do it, but I don't make as many cakes as I used to because I have 2 young kids and I don't like messes and they always wanna help, and I'm not into that.
Fair enough. Fair enough. Okay. Last question. Who's the one person, famous or not, living or not, that you would most love to sit down and have a conversation with and why?
This is a hard one. I think it would probably be my mom's dad, and I never met him. Um, and my mom is was very close with him, but also very um, inspired by him. She was the youngest of 10 children, so I would
Oh,
just
wow.
love to hear. And my mom's a physician, and um, in that time in India, culturally, raising a daughter after 7 boys who never were really professionals, like, the fact that he thought about raising a daughter to be a doctor and putting her through medical school, it's just so interesting to me. And I think both of my grandfathers and both sets of my grandparents were very forward thinking for their times. So I'm always curious to see kind of what he thought about life and what he thought she would become.
I love that. Well, that's beautiful. Okay. Well, thank you. This has been fascinating. If people would like to learn more about Hey Healthy, what would be the best way for them to get more information?
Yeah, heyhealthy.com. We have a nice, new, beautiful website that I would love for you guys to look at. If you're interested or curious, go ahead and fill out our contact box. I'll get the email and I'll respond to you directly. And I'll be happy to chat with you and tell you all the things about Hey Healthy.
That's awesome. Well, thank you again so much for your time. This was absolutely fascinating. Like I say, I could talk for hours with you about this subject, but thank you for the time you did give us today. I really appreciate it.
Thank you so much for having me.
Bye bye.